most welcome for this webinar. Thank you for participating.
Thank you for inviting.
Thank you.
Pleasure.
Okay. Nehal, there are the first topic is yours, na? ICU resource management.
So,
Yeah.
Venugopal sir, so
Yeah.
actually we will slightly change the order.
Okay.
So Nick would like to go first with his talk on
Ventilator management.
Yeah. So I just for the people who are here, I just wanted to say a few words about Nick.
Nagesh, 1 minute. This is right now, the time is 6:54.
Okay,
6:54. Just another 6 minutes more. Meanwhile, let's chit chat a few things. Once all the members and chairpersons done it, then you can do the introduction. Though everybody will take the message. Well,
Sure.
may I know what are the cause for the settling of cases in UK?
Sorry, come again.
What are the causes for the settling down of COVID cases in UK?
So, Nick, would you like to take the question?
Why have the cases come down?
Yes.
Yeah. Reason.
I think there's been a
Mahesh
fairly
garu, good evening, Andy.
Good evening.
good evening. There's been a fairly
Good evening, good evening.
comprehensive,
Good evening, sir.
lockdown that's taken place in the UK. There's been a fairly devastating effect on the economy. People have been taken away from the workplace. The schools have been closed. The shops, the restaurants have been closed for a prolonged period. And I think that's the thing that's got on top of the epidemic, as far as we can see. As soon as things have been gradually started to ease and shops and restaurants have started to open, then cases have started to creep up again. And I think that's been the experience of the rest of Europe as well.
So, as Nick said, Europe is relatively a less crowded part of the world. And I think as we are seeing, the crowded parts of the world are taking the brunt of it at the moment. As you can see, the United States, India, and Brazil, as the populations are high and it's difficult to maintain less crowded conditions, are facing the brunt of it. I think Europe had seen the worst part of it, and because the individual behavioral characteristics are slightly easier, I would say, to maintain in this part of the world. And that's probably the reason why the pandemic has largely come under control here. And as Nick said again, it is very difficult to see how this is going to go when everything opens up and when we try to put the economy back on track. It would be very interesting to see what happens.
Okay.
Yeah, you must be correct, because the population of UK is about 6.6 crores, almost equal to that of Andhra Pradesh. So naturally, you have got the population advantage
That's right.
there when compared to India.
Yeah, the one is a population advantage, not just the size of it and and also the density of it, and and also I would say it is because it is a relatively well-developed economy. The government has been able to support large portions of people when the nation was in lockdown. It is slightly difficult to sow in India when a large number of people are dependent on their daily wages. So I think there are a number of socioeconomic factors here.
Yeah.
Fine. Dr. Mahesh Babu garu?
Yes, sir.
It is 6:58. Shall we start in a couple of minutes? Because
Yeah, we can start. We can start by 7 o'clock sharp.
Yeah. Okay, sir. Fine.
To all, sir, sir, Mahesh sir, and Kiran sir.
Good evening, Srinivas garu.
And Achyut also is there, sir.
Oh, nice.
Good evening, sir.
Good evening, Andy.
Good evening, sir. Venugopal sir, Mahesh sir.
Good evening, Andy.
Good evening,
బాగున్నారా?
Achyut.
అచ్యుత్ బాగున్నారా?
Good morning, sir.
Good evening, sir. Venugopal sir.
Good evening, Sri Mohan Maharaj garu. Good evening, Andy. Srinivas garu. Most welcome.
Good evening, Mohan Maharaj garu.
Good evening, sir. Mahesh Babu sir.
Good evening, good evening.
How is the work going on, sir? Mohan Maharaj garu?
Still going on.
You are taking up of this care hospital.
Yes, sir.
It's completely COVID.
Yeah.
How many bedded?
75.
75 bedded. Okay.
Is
You
the
ward
hope
plus
for
ICU.
entire is the hope for entire Srikakulam, Vijayanagram, East and West Godavari districts, sir. Is the only hope for us.
Good thing, na, sir. Because we have a lot of moral support.
Yeah.
Positive also, more, sir, is there.
Yes, sir.
That is very important, sir, because if you have one faith, some support with our faculty also, so we will be, the patients will recover very fast.
Definitely.
Fear is the more important.
Yeah. Today somebody was talking about the vibration in the patient. So probably the vibration will come with a positive attitude there.
We almost treated 1,200 patients, sir.
Congrats.
Congratulations, sir.
Sir, yesterday you missed it. Actually, your photo was showed as a COVID warrior yesterday. So a big photo of yours was shown yesterday as a COVID warrior.
Thank you, sir.
Mohan Maharaj garu, he don't know that. So we prepared one video.
Video
You are
and
one of the
showed
most
it.
important frontline warrior along with the
Almost
Brigadier
you are like a mega hero in that.
Today is a 126th day, sir. Today is a 126th day. Every day I am doing rounds by God's grace without any quarantine.
Sir, are you taking a prophylaxis?
No, sir. The only thing is every day steam inhalation for 3 times.
Okay, 3 times. And what about gargling?
No. Only steam inhalation.
Steam inhalation with the carval or turmeric?
It depends. Pasupu.
Best. Turmeric is best.
Good.
All the warriors only, they won't take any prophylaxis, sir. What I observed. And they don't want to bother the treatment also. Yesterday, also, these are told any asymptomatic case, there is no need of treatment. Just leave him, give him just paracetamol, that's enough.
Every second week I get my test done.
You just go for RT-PCR or?
RT-PCR. Every second week I get my RT-PCR done.
Same protocol, sir. Here also we are taking, sir.
And last week I did my antibodies also. It has come 0.
Okay.
So it's 1 minute.
We have to take possibly that your PP is working very well and you're not exposed.
No, we are more worried. Antibodies are. The time is 7 o'clock. We'll start, sir. Thank you.
Yeah, we can start.
So the host of the Zoom meeting, can they unmute everyone except the speaker? The first speaker will be Nick Coleman.
Yeah.
So I request that you unmute everyone else.
Nageshwar, as per the protocol, we'll start the meeting. Followed by in just couple of minutes, we'll mute everybody. Okay. Sure. So Srinivas, please start the program. My secretary, Srinivas.
Good evening, sir. I am Dr. Srinivas Rao Suriseti, secretary.
Sir, unmute yourself, sir. Unmute yourself, sir. Sir, unmute yourself.
Vedu, sir, please carry on, sir.
Yeah.
Yes, sir. Audible.
Vedu, sir, please. Welcome you all once again. Our president will take over. Vedu, sir, unmute yourself.
Very good evening, respected ISA leaders, senior members, dear friends. Dr. Srinivas, my secretary, treasurer Rachit Ramaya, Dr. Mahesh Babu garu, past president ISA, Dr. Kameshwara garu, Dr. Chakra garu, Kuchel Babu garu, Dr. Chairpersons, Dr. Srinivas Gondi, Dr. Mohan Maharaj garu, and today the guest speakers, Dr. Nehal, Dr. Nick, Chris, and the moderator, Dr. Nageswaru. Welcome all. Today the chairpersons are the Dr. Mohan Maharaj Garu, Dr. Srinivas G, and Dr. Mahesh Babu Garu. These three are the dynamic and very academicians, and will participate in almost all the state, AP state and national conferences. I welcome all. With this, I am handing to Dr. Nageshwar, who is moderating this session. Over to Nageshwar on the board. Thank you.
Thank you very much for the opportunity. So myself, Nick Coleman, Chris Thompson, and Nehal Patel, we are all consultants in intensive.
Sir, Nageswar, sir, please. Yes.
So we're consultants in intensive care medicine at Royal Stoke University Hospital. It's located in North Midlands in United Kingdom. We are a large university hospital. We have a medical school, Kiel Medical School. And as the whole world has witnessed, UK had its share of the problems with the COVID crisis. And we faced the brunt of it during March, April, May time. And we have come into the recovery stages of it at the moment. And this was a great opportunity for all of us to share our experiences with our colleagues in India, who is now facing the crisis. So we take it as a very good opportunity to share our experiences and see if our colleagues in India will benefit from our experiences. And this is also a great opportunity for building future partnerships. So I would like to start with Nick Coleman, who is a consultant colleague of mine. He's a senior intensive care consultant. He has an anesthetic background to start with, but Nick is predominantly an intensivist at the moment. He's also a significant member of our senior management team. He had taken quite a significant role in planning the whole of the management of the pandemic crisis for a large institution like ourselves. So Nick is a associate medical director and responsible officer for the University Hospitals North Midlands NHS Trust. He's an excellent clinician with a specialist interest in echocardiography. He's accredited with the British Society of Echocardiography, and also has a special interest in mechanical ventilation. Thank you, Nick, for this opportunity to share our experiences with our Indian colleagues.
I need to share my screen, don't I? So.
Sir, please allow Nick. Share screen, sir, Nick, sir.
Can you see my screen or not yet? No. Just turn it on a second. Zoom. I'm just trying to get my presentation to share. Nagesh, have you got my presentation or? Nagesh?
Bedu, sir?
Yeah. Yes.
Nick, sir, they share.
Okay. Wait, please wait.
Nagesh, are you able to load Nick's presentation?
Yeah, I'm doing that.
Oh, thank you.
Yes, sir.
Can you see my presentation?
Yes, sir. Yes, sir.
Okay, can you see that now?
Yeah,
Yes,
fine.
Okay.
Please.
Great, right. Okay, well, thank you very much for the opportunity. I very much appreciate the opportunity to be asked to just share a few of our experiences with you today. I've been asked to talk largely about respiratory management other than invasive mechanical ventilation. I can talk for a long and tedious time about mechanical ventilation, but I've been asked to stay away from that for the duration of this talk. So in terms of the evidence around ventilatory strategies, I think it's fair to say that it is rapidly evolving and also of a fairly low evidential level. It's a mixture of very small case series, so at times not very impressive case reports, and a lot of anecdotes written in various peer and non-peer reviewed journals. And before we do formal and agreed changes in patients' management, we do need to get a little bit more scientific rigor around ventilatory strategies than we currently have. I'm sure Chris will talk later on about the UK drug trials, and that was an example of a very high quality method of establishing evidence-based treatments in a very short time. And the same rigor, unfortunately, for many reasons, has not been as well described in respiratory intervention. So what we've got is largely a mixture of case series, case reports, and some anecdotal evidence. So as is the case for all respiratory illnesses, there is a ladder of respiratory support that starts with low flow oxygen by face mask, which has clearly got a significant role in the majority of patients with COVID pneumonia. High flow nasal oxygen, which is available in some places and not others, but is becoming increasingly popular for all sorts of reasons. Continuous positive airways pressure, non-invasive mechanical ventilation. I don't know why my screen keeps doing this, but and obviously invasive ventilatory support. There is some relevant physiology that I think if you're going to apply various respiratory strategies, we need to understand the peculiarities of gas exchange and respiratory physiology in COVID-19. And probably the most important thing is the level of arterial hypoxemia in these patients does greatly seem to exceed the abnormalities in their pulmonary mechanics. The pulmonary mechanics, at least in the early phases of their illness, are relatively normal. Now, I understand there are significant issues in terms of pulmonary microthrombotic disease, but in terms of pure pulmonary mechanics, the abnormalities are not significantly severe. The degree of hypoxemia that patients experience is very significant. And there was a phase early in the pandemic, certainly in the UK, and I think from what I can gather this was true in Europe and in the US, where many patients were intubated largely because of the extent of their hypoxemia. But they weren't particularly short of breath and they weren't particularly distressed. And the concept of the sort of happy hypoxemic has been much publicized across the world. Tobin, if you're not familiar with Martin Tobin, he's an American physiologist and respiratory critical care physician. Doesn't think this is particularly surprising given the pathology of COVID-19, but there was a period where people were intubated largely because they were significantly hypoxic, not because they were significantly distressed. Also, tachypnea has been used as an indicator for intubation, largely as a proxy for an indication of the extent of the increased work of breathing. And again, Tobin's very clear that tachypnea is of itself a physiological response to lung inflammation and not by itself a sign of increased work of breathing. Work of breathing is actually determined by the magnitude of pleural pressure swings and the associated tidal volume per change in pressure. You're probably all familiar with the two potential different phenotype and physiological presentations of patients with COVID-19, the so-called L and H, the low and high compliance features. And here's a couple of scans. The scan on your left is the so-called low or L type, and patients with type L have got low elastance, so they're relatively high compliance.
So your presentation.
Nick,
The
can I
tendency of
interrupt
the
you for a
lungs to
second?
collapse on themselves is not significant. So the elastance is low. The
Nick.
lung weight is also
Doctor.
low. And
Sorry.
the recruitability of the lung and therefore
Dr.
the
Nick.
response to...
Nick, sorry.
Dr. Nick.
Yes.
Your screen is missing again. Is it possible to reshare again? Sorry, your slides are missing
Sure.
again.
Oh, sorry, is it keep going? Hang on. Where did you get up to?
One slide up. Yeah, from there.
From there, okay. Okay, in this slide, is that better? Yeah.
Yes.
Yeah, okay. I was just articulating the fact that the relevant physiology is important in terms of interpreting how we establish different respiratory interventions. And the next slide just shows you the difference that Gattinoni proposed of the different types of lung injury that you see. And the screen on the left shows you the type L version, so-called low elastance, low lung weight, and low recruitability. So the response to PEEP in patients on the left-hand side of the screen is likely to be low. On the right-hand side of the screen, you can see a much more typical so-called type H features where they have a high elastance, a high lung weight, and a potentially high recruitability. And that's much more typical of a normal ARDS patient that we're all largely familiar with. So what about face mask oxygen? It's fine for the vast majority of patients in hospital. The things to remember about face mask oxygen is that it's not humidified at low flow, and it's not as well tolerated as we probably all think it is. Oxygen, when it's given and unhumidified, has a time frame. Patients don't tolerate it for all that long in some significant case series. The other thing to say about it is the inspiratory flow that the patients take is much higher often than the delivered flow. So the FiO2, the actual fractional inspired oxygen concentration that patients breathe, is variable, and it's often much lower than we think it is, and it's much often lower than is actually required. So clearly we want to avoid hypoxemia in patients receiving supplementary oxygen. If you look through the literature, you'll see there are a large number of different oxygen saturation and partial pressure of oxygen targets. And essentially you can choose whichever one you want. The WHO have got one, every specialist society has got one. I think most people would say that somewhere in the early 90s is fine for the vast majority of patients. The higher up the oxygen requirement you go, people will tend to accept less. And most people would say that oxygen saturation targets of between 88 and 90% are acceptable for the vast majority of patients. What about high flow nasal oxygen? And this has become increasingly popular over the last few months. It's not available everywhere in the world, but as I say, it's become much more popular. And if you look back at high flow nasal oxygen, the seminal paper in this was published in 2015 in the New England Journal of Medicine. And this was a multi-center study done in Belgium and France, looking at the effect of high flow nasal oxygen, that's usually considered to be 20 liters per minute of oxygen or above, delivered to patients with, most of these patients had community-acquired pneumonias. And you can see from this slide the effect of high flow oxygen on the overall study population. And you can see a non-statistically significant but reduced incidence of intubation and mechanical ventilation in patients treated in this way. If, on the other hand, you look at patients who were much sicker, the sicker end of the spectrum, so patients with a PO2 FiO2 ratio of less than 200, so the sick end of the spectrum, there was a statistically significant reduction in the incidence of intubation and mechanical ventilation in these patients. So clearly you were less likely to be intubated if you had high flow nasal oxygen and you had significant hypoxemia. The other interesting thing to say about this, as you can see from the Kaplan-Meier curve, is this translated into a statistically significant difference in mortality in these patients. So this was the first significant paper that demonstrated that the use of high flow nasal oxygen improved mortality in undifferentiated patients with acute respiratory failure. Now, the question you probably all want to know the answer, I think everyone wants to know the answer is, how does the studies from populations like this of an undifferentiated etiology apply to patients who all come in with the same thing? In other words, does this work as well in patients with COVID-19 as it does in undifferentiated patients with a variety of indications for acute respiratory failure? The initial view in the UK was, and this is a consensus statement from the Faculty of Intensive Care Medicine, the Intensive Care Society, and the Royal College of Anaesthetists, was essentially, you probably shouldn't be doing this. This was the early view of august societies in the UK. It should be avoided. There was no survival benefit compared to conventional oxygen therapy. quite how they came to the conclusion there was no survival benefit in patients with COVID when there was no evidence to say one way or the other is difficult to understand, but that was the initial view. The other thing to remember about high flow nasal oxygen is it uses a lot of oxygen. And one of the big issues that UK, European and US ICUs have had, and UK hospitals have had over the COVID, is a relative shortage of oxygen, which nobody ever anticipated when this pandemic started. The demand on oxygen is absolutely vast when you have large numbers of ward patients taking oxygen and patients in ICUs having high flow oxygen and CPAP. High flow nasal oxygen is heated and humidified, and it's therefore much better tolerated than normal face mask oxygen. It's also significantly less claustrophobic. It provides a small amount of PEEP because of the high inspiratory flows. And I think most people's view is that if intubation levels can be reduced with high flow nasal oxygen, then it should be part of everybody's armamentarium. In terms of pure evidence about this, there's not a huge amount published. There's a couple of large case series that have been published, but to be honest, they don't really concentrate particularly well on the COVID-19 issue. And I've just included them for completeness, but essentially the jury is still out in terms of whether you can translate the evidence that's been accumulated in undifferentiated causes of respiratory failure to patients with COVID-19. So I think it's fair to say that it's of uncertain utility at the moment, but its usage has increased significantly over the last few months. It will undoubtedly prevent intubation in some patients. There are issues with local maximum oxygen outlet delivery, which I'm sure all your hospitals have come to the conclusion at broadly the same time that we did. This was a problem that probably could never have been anticipated. The big concern about high flow nasal was the risk of environmental viral contamination. And in the UK, it's treated as an aerosol generating procedure, and appropriate personal protection needs to be taken into account when patients are receiving a high flow nasal for the staff around them. So it's an AGP in this country. What about continuous positive airway pressure? Slightly strange in that patients seem to respond to CPAP and PEEP in this way probably better than patients with the so-called type L, the low elastance, high compliance patients probably should. But certainly anecdotally, from an oxygenation perspective, they do seem to respond to it. Again, CPAP is a large consumer of oxygen, therefore has to be treated with some caution. I think it's worth a trial in patients. We've certainly used it quite a lot to see if mechanical ventilation can be avoided in certain selected patients. And patients who don't respond to CPAP at all are generally considered as an indicator for early intubation. We've certainly looked at low flow CPAP devices, but being used outside the ICU using entrained oxygen in order to reduce the burden on the oxygen supply. And that does appear to be suitable for patients with a lower oxygen requirement. What about non-invasive ventilation? Well, again, theoretically, non-invasive ventilation with biphasic positive airways pressure is usually not needed and should not be needed in patients with otherwise normal lungs. While they are significantly hypoxic and their hypoxemia is not consistent with the change in their pulmonary mechanics, one thing they rarely do is retain carbon dioxide, and increasing ventilation is unlikely to improve things. Compliance is also usually pretty well maintained in the early phase in patients with COVID-19. And I think people's general view is that non-invasive ventilation should be reserved for patients who've got some reason to be hypercapnic. So in other words, patients who've got acute exacerbations of chronic obstructive airways disease on a background of some chronic hypercapnia, and patients who've got cardiogenic pulmonary edema. Now, having said that, there have been a couple of case series of investigators, and this one I've included here is from the REACT investigators in Southampton, who have used non-invasive ventilation as their primary course of treatment in patients who come in with a certain level of hypoxemia. And these authors in Southampton, excuse me, in Southampton have actually described some quite good results in patients treated with NIV. So what about any other respiratory management? Awake proning is something that I'm sure you're all aware of, and something everybody who's managing large numbers of these patients should be very, very careful about, because it's got some potential significant benefits. There's a nice commentary about this in the New England Journal of Medicine called "Prone Positioning in Awake Non-Intubated Patients. Necessity is the mother of invention." And essentially what they were saying was, when there's such an unprecedented demand on intensive care services, we have to think of new and nominal and innovative ways of trying to treat patients without intubating them all, because clearly hospitals would be under far too much strain if we did that. And there are some significant benefits of proning patients in the awake position, not just waiting until they're mechanically ventilated. And it seems to have all the same benefits as it does when patients are mechanically ventilated. You do get recruitment of previously collapsed alveoli in the posterior elements of the lung, and you do get improved ventilation perfusion in patients in the prone position, whether they are awake or asleep. The benefits seem to be maintained for a number of hours after the prone position has been, the patients have been turned back supine. Again, there have been some case series. This was a series of 50 patients who presented to an emergency department in New York City, who had early self-proning. And again, from an oxygenation perspective, these patients had a very significant improvement in the first few hours. And every hospital now has got some sort of awake proning algorithm. And I'm sure all your hospitals can develop their own based on your local circumstances. But essentially, I think it's fair to say awake proning probably is part of the tools in the box for most units who deal with large numbers of patients who come in with COVID-19. Here's one from Bao and Han-Yong published in June. Here's another one from a Chinese author. But essentially, you get the idea that awake proning has become part of everybody's armamentarium. The other thing to say is that awake proning can also be used in combination with all the other therapies I've talked about. You can prone patients just receiving low flow oxygen, you can prone patients using CPAP, and you can prone them in combination with high flow nasal cannulae. It's mainly anecdotal so far. It appears to be safe, and it may slow the deterioration in selected patients who otherwise would require higher levels of care. It may reduce the demand for invasive mechanical ventilation, and it's simple and it's clearly cheap. There are some concerns about it though. It requires quite a lot of close input from nursing staff. Patients need a lot of support and encouragement. It's quite an unusual thing to ask patients to do. Probably the biggest concern with proning, awake proning, is that it will produce a short-term benefit and the numbers will look better, patients' oxygenation will look better, but their outcome will either be the same or potentially worse. And nitric oxide, which some of you undoubtedly use and are familiar with, improves oxygenation in these patients, but has never been demonstrated to improve outcome. Patients in the ARDSNet study, for example, in the higher tidal volume group, who were more likely to die in the ARDSNet study, had better oxygenation when they died than the low tidal volume group. So we've got to be careful about things that produce potentially short-term cosmetic benefits. So there are concerns about awake proning, and although it's been very enthusiastically adopted, it probably should be subject to a randomized controlled clinical trial. And we still should have equipoise as to whether awake proning should be a permanently adopted feature. So in terms of how you'd summarize non-intubation strategies, it's probably fair to say that oxygen consumption can be a significant problem. And that's a problem in the most well-resourced units in Europe, North America. Everybody's got a potential problem with oxygen. High flow nasal oxygen appears to be safe. It appears to be very well tolerated in patients, and it probably does reduce intubation rates. But again, we probably do need a randomized control trial to demonstrate that's the case. There's been no proven mortality effect published so far in patients with COVID-19. Non-invasive ventilation's probably got a role, but only with certain subset of patients who are subject to retaining carbon dioxide, in other words, patients with COPD, and certainly in some patients with cardiogenic pulmonary edema. Proning is likely to be a good thing in awake patients, but again, it may be a short-term cosmetic benefit. There are compelling physiological reasons why it should be a good thing, but again, we probably need to demonstrate that. And again, one of the most important things, it's important not to delay intubation where all the clinical signs are telling us that intubation is failing. I was just asked to say a couple of things about proning at the end during mechanical ventilation, and are there any differences in proning COVID patients to proning patients who've got any other acute respiratory failure? Every specialist society has got their own guidance for how to perform prone positioning in adult patients safely, and the Intensive Care Society has got a very nice document which is available for anybody to see. I would say that our experience was that, yes, it improves oxygen. There's no doubt about it. In the vast majority of patients, their oxygenation improves. We should start early, and the earlier the better. It's also true in COVID, which I think we've had quite a lot of experience with, is that it needs to be done for longer and it needs to be done more frequently. And we've had a number of patients who've done extremely well, who've been proned far more frequently and for far longer than I think we've ever had any experience with before. The potential problem with that is we've had a significant increase in pressure damage, facial pressure damage, which I think is, again, something that all hospitals in the UK are very understanding of and have tried to put in strategies to reduce that. There's also, we've had a patient who had a brachial plexus injury as well. So there are, again, proning is not without its complications, but I think if it's got a mortality benefit, I think patients will take some pressure damage as a consequence of that. It's very staff intensive. It's not particularly resource intensive. It's very staff intensive. And you need to get staff who are well trained and well drilled in how to do that. And to give you an example of how well entrenched proning has become in the UK, even the British Orthopaedic Association, the Orthopaedic Society of the UK, published a guide on how to prone patients for orthopaedic surgeons. That just shows you how well entrenched proning is, certainly in the UK and North America. So I'll conclude on that note. If anybody's got any questions, I'll be happy to answer them.
Thank you, Nick. There is a couple of questions from the participants. I'll ask them if none of the chairpersons have any questions for Nick.
Dr. Mahesh Babu garu, Dr. Srinivas, Dr. Mohan Maras.
Some questions about this.
Yeah, sir, please go ahead. Sir, is there any questions on the chat box?
Yes, so there is a couple of quite valid questions for you, Nick, from Dr. Ajay Rakesh Verma. So one is the evidence behind aerosol generation and infectivity with high flow nasal oxygen. Is there any evidence behind aerosol generation and infectivity with high flow nasal oxygen?
There is. There's people who've done all sorts of very clever experiments on high flow nasal oxygen and measuring mist and droplets and all sorts of things. And I think the general view is that it is more of an error. I mean, obviously mechanical ventilation is in itself not an aerosol generating procedure, but high flow nasal definitely is. It does depend on all sorts of patient factors and how far that aerosol generates. I think the view in the UK has been taken recently that anyone within 2 meters of the bed space of the patient who's on high flow nasal oxygen should wear personal protective equipment, but anyone in the same room doesn't have to. And that's some guidance that's recently been agreed in the UK and guidance that we are following. So yes, it's an AGP, but you don't have to have everybody in the room as long as appropriate distancing is practiced.
Excellent.
I have a question for you, to Dr. Nick. Can I ask?
Srinivas, please.
Yeah. Suppose if you're using a high flow nasal oxygen, are you going to use a nebulization with a steroid? Yeah, nebulization with a steroid.
For what reason?
Because they say nebulization with the steroid has also a beneficial role in controlling the hypoxia and hypercarbia?
Well, I think the only drug treatment that's currently been proven, as I understand it, is intravenous dexamethasone, which is part of the trial, the recovery trial that was in the UK that I'm sure Chris will talk about. In terms of inhaled steroids having any kind of high-level evidence to reduce morbidity or mortality in COVID patients I'm not aware of, you can certainly use nebulizers in conjunction with high-flow nasal oxygen, but I'm not sure in nebulized steroids, certainly that's not something that we would use.
But there is the recent article has come up, I don't know because I just forgot. The salmeterol, that is methylprednisolone, can be used as a nebulized steroid, which shows that it has definitely proven to be reducing the hypoxia. They say the saturations are definitely better with the nebulized salmeterol. Do you practice that?
No, but again, I don't think we've got to be careful of simple changes in gas exchange as being proxies for improvements in mortality or improvements in morbidity. And again, nitric oxides taught us this, the ARDSNet studies taught us this, that we need something more evidentially impressive than just somebody's oxygen saturation went from 90% to 93%. Because in of itself, that doesn't improve the situation for the patients very much. What they want to see is an improvement in outcome and a reduction in intubation and a reduction in death. And physiological changes like that are not particularly helpful, I don't think.
So we'll ask you one more question, Nick, and I think this is probably the biggest dilemma of every single intensivist in the recent times is how do we balance, so this is again from Ajay Rakesh Verma and several others in the chat group, how do we balance the risk versus benefit of early intubation or early mechanical ventilation? How do we judge with the right time to put somebody through the mechanical ventilation?
Well, that is the most difficult question. And I think that is something that is based on accumulated experience with an individual pathology. And I think I can't speak for others, but my view is that we've changed our approach a bit over the last few months. And I think one thing that we've done is I personally would thinking with intubating patients purely on worsening gas exchange is not necessarily appropriate. There are some patients who can tolerate low levels of PO2 for significant reasons, for significant lengths of time, as long as their respiratory mechanics are reasonable. And Tobin's written a lot about this and about comparing, for example, if you go to the top of Mount Everest, you'll have a PO2 that's, will be 4 kilopascals, but that's not an indication for you to be mechanically ventilated. You'll become a bit tachypneic, you won't feel very well, but you don't have to be mechanically ventilated. A lot of intensive care clinicians in the UK took a lot of readings on the top of Mount Everest, and they had ridiculously low oxygen saturations, but nobody jumped on them and intubated them. I suppose what I'm saying is it's a careful clinical decision based on a lot of evidence, of which gas exchange is one. I think cardiovascular changes are another. I think patient distress, anxiety, to some extent tachypnea, work of breathing. I think it's one of those things you have to stand at the end of the bed and look at them for a period of time and make a decision on the best evidence that you have. But I think hard cutoff points for things like PO2 and oxygen saturation are poor proxies for decision making. Otherwise, every high altitude mountaineer would have to strap a ventilator with him everywhere he went. And I think he's written a couple of really good articles on this, they're very sort of solid respiratory physiology approaches to the problem of COVID.
Thank you. Venu sir, can we move on? Excuse me.
We can move on to second lecture, sir.
Yeah, so just
Nagesh, with your kind permission, I will take only 2 seconds.
Yes, please, of course.
I heartfelt welcome Dr. Chakarrao Garu, Dr. Kameshwara Garu, Dr. Bhimesh, Dr. Kiran Kumar Gera, and my senior members and IAC leaders. Please welcome. Over to Nageshwar, please carry on.
Dr. Nageshwar.
Yes, Dr. Maharaj. Yeah, do you have a question for Nick?
Yeah, small question. When exactly you would like to start nitric oxide?
Well, again, we don't use nitric oxide. And again, there's no, I'm not sure about this, but I'm not aware of any evidence base for the use of nitric oxide in COVID-19. It's certainly been studied fairly extensively in ARDS patients, and it's been demonstrated to improve oxygenation in those patients in a significant proportion of them. It doesn't appear to change the outcome. So it's quite an expensive intervention. It's quite technically difficult to provide in most ICUs. It's got a similar evidence base to inhaled prostacyclin, so nebulized prostacyclin, which again is a pulmonary vasodilator and does largely the same thing. It does improve ventilation perfusion matching, but it doesn't appear to improve outcome at all. So I think nitric oxide, certainly in the UK, is largely confined to acute respiratory failure in neonates and small children. And in the adult world, I think it's not gained any traction in the UK. It's technically difficult, and it just seems to have what seems to be a largely cosmetic effect on oxygenation. So it's no consolation to patients that they die with better oxygen numbers. So unless it has a demonstrable improvement in outcome, it's not going to catch on in the UK. I'm sure that's not everybody's view. I think it's used a bit more in North America, but I think in the UK and Europe, it's not something that's really talked about very much anymore. It was popular probably in the late 90s, early 2000s, and I've certainly used it before. And again, in some patients, it's appeared to change the numbers in a very positive way, but in multi-center trials, it didn't seem to work.
Thank you.
Okay.
Thank you.
So,
Dr. Nick, the last question, experience with you about ECMO in UK?
Well, we don't do ECMO ourselves. We in the UK, ECMO is organised in, I think it's 5 specialist centres in the UK who run a retrieval service to take all suitable patients for ECMO. Anecdotally, I heard early on that their experience in COVID patients was poor and the patients weren't doing very well. But I've heard from somebody else recently that things had improved and that they thought ECMO was a valuable adjunct in patients who essentially had nowhere else to go. So I think, you know, if you can provide ECMO in an experienced centre, then I think it's probably a good thing to do. And the others might correct me. I think we've sent 2 people for ECMO, and I think 1 died and 1 didn't, is my recollection, but somebody might correct me, which no, clearly is a very, very small case series. But as I say, I think the general view about ECMO mortality generally is that it's not something you can do once or twice a year. It's something that has to be organised into a large volume. In your area, I imagine it would be statewide. In the UK, it would be national, a national plan to deliver high volume ECMO in a safe and high quality fashion, rather than just saying we will try and do some veno-venous bypass occasionally. That clearly doesn't work.
Thank you, Dr. Nick. Thank you.
Okay. Thank you, Nick. We have to move on. There is a lot of questions about drugs in COVID. I think Chris is going to talk about pharmacotherapy, so we can take these questions on pharmacotherapy after Chris's talk. And I just want to say thank you to Nick for his for his lecture. And one thing I wanted to share my experience is this happy hypoxia that Nick mentioned on top of the mountains. I wanted to give a personal perspective that when I climbed onto Torangla Pass, which is about 5,400 meters last May, we had a group of 5 people, and all our oxygen saturations were in 80s, and none of them required mechanical ventilation. So this, I think with the COVID, what we had seen is something, the hypoxemia very similar to a high altitude hypoxia. And this definitely has changed our perspective in targeting one particular number or one particular figure. And I think we had seen a large proportion of happy hypoxics that we had ever seen before. Nick, do you agree?
Yeah, I do agree. Yeah, that's not to say it's a good thing and that we shouldn't keep an extremely careful eye on these people. And I think many of them will be intubated at some point, but there's some who won't. And I think before we rush into it too early, we need to look at other clinical information rather than just concentrate on looking at some numbers.
Brilliant. Chris, so we'll move on to the next topic, which is essentially is a topic of a lot of importance, particularly in India, because the usage of pharmacotherapy is as compared to so because I've got established links with people in India, and quite constantly the most common question is can we use this drug or that drug, and there is a lot of reliance on drugs in particular. So I wanted to I want to introduce Chris, who is again my consultant colleague in intensive care in Royal Stoke University Hospital. Chris is also a consultant in renal medicine, consultant nephrologist. He brings in a lot of value as a consultant nephrologist practicing intensive care at the same time. And he's a very senior intensive care consultant. And one particular thing that I wanted to mention with regards to COVID is he's also our research lead for our intensive care unit. And, there was a lot of discussions and meetings on participating in research during a pandemic, and it did not definitely seem to be a good thing to do, when the whole nation is facing a crisis. But we have come to an agreement that this is possibly the time to participate in a well-conducted, quality controlled, and this is probably actually the biggest need for a well-conducted research. And Chris was our main force behind driving research in our critical care unit, and we are so that we have been a significant part of the recovery trial. So thanks to Chris that as a unit that we have participated in this groundbreaking study, and I will hand you over to Chris.
Thanks very much, Nagesh. It's a great pleasure to speak to you all. I'll share my screen if I can. Hopefully I won't have quite the same difficulties that Nick had. Oops. So I was asked to talk about pharmacotherapy in COVID and emerging evidence. So I think there are a number of givens that we have in terms of what we practice in the UK. So anyone that comes into hospital will get DVT prophylaxis with low molecular weight heparin, a standard dose, adjusted for their renal function. So most people get, in our institution, deltaparin at 5,000 units. The other thing that is commonly done for us in the UK is that when you have someone who presents with a community-acquired pneumonia picture, they'll get given some antibiotics. And in the COVID crisis, we were no different to anyone else, and patients who came in got given antibiotics. And then clearly oxygen therapy, Nick has talked extensively about. Bronchodilators have been mentioned, and we use bronchodilators in people who had wheeze. But then we started to limit things significantly to we have no evidence for using anything else, and we will stick to standard care. And we did rigidly stick to standard care, apart from if a patient was participating in a research study. And I'm going to try and go through some of the evidence around that. One of the biggest things that we noticed, as I'm sure around the rest of the world, is that there's an explosion of COVID research. And I've been online today and had a look at clinicaltrials.gov, and there's currently 3,000 trials registered for COVID studies alone. But one of the biggest learning things that we had from previous pandemics, particularly the Ebola outbreak, was that unless you had large, properly conducted clinical trials, you end up finding that you don't have any recognised treatments at the end of a pandemic. And the UK has done exceptionally well in terms of mounting some very large public health studies that have been prioritized by the NIHR to enable us to find some useful interventions and to also quell the myths about some others, and I'll try and go through those. We clearly, in the process of looking at all these different drugs, have repurposed a lot of drugs, and most of these drugs have never been designed to treat this particular virus, and it's very important to recognize that when you're trying to deal with a new contagious agent, that you are having to rapidly respond in a way that you've never had to in the past. And as a consequence of that, a lot of clinicians started to use drugs and treatments on compassionate grounds because they thought it was the right thing. And clearly there are potential harms or benefits from that. And often when you're using drugs that you're using on compassionate grounds, the harms probably outweigh the benefits because you don't know what you're doing. And even as you get more evidence that's arriving at you, it's sometimes really difficult to work out what evidence you should go with and what evidence you should park and not use just yet. So I'll try and run through some of that. Clearly, one of the biggest advantages that we had in this particular pandemic was the International Severe Acute Respiratory Emerging Infection Consortium, ISARIC. ISARIC have recruited over 100,000 patients into an observational study looking at the characteristics of COVID-19, and that has enabled us to understand this disease very, very quickly and understand why people become ill and which people become ill. And by the 15th of May, we'd already had a cohort study of 20,000 UK patients published in the UK, which showed that these patients that were getting really sick tended to be predominantly older and more comorbid. And that colours how you potentially manage people, but didn't really explain how the interventions that were going through just on compassionate grounds were being used. But early on in the ISARIC study, there was about 10% of patients in the UK that were getting steroids in some form. That reticence in terms of doing unproven interventions meant that the UK was in a very privileged position to then look at different drugs. And there are two clear front runners in terms of evidence that favour their use in COVID-19, and that's dexamethasone and remdesivir. But dexamethasone, the evidence base is the recovery trial, and I'll go into detail with that in a second. And that was purely a UK trial. But remdesivir was studied as part of a multi-centre international trial, and I'll go through that as well. The platform trials that the UK have adopted have been incredibly useful. So it basically means that you've got several studies out there that are looking at multiple drugs that and comparing them to a single control arm. The advantage of that is that you can look at these drugs much more rapidly because you don't have to recruit a control arm every time. And the recovery study started out with basically all comers with COVID who were hospitalized, aged over 18, and have managed to randomize 12,219 patients in 176 active UK sites. And Their initial study protocol included Kaletra, which is ritonavir HIV drug, as one arm, dexamethasone, hydroxychloroquine, and azathioprine. And then they've subsequently added in teclosamab and convalescent plasma. Convalescent plasma is quite interesting because in the UK, we haven't used convalescent plasma that much outside of clinical trials. But if you go over the pond to the States, then they've used convalescent plasma about 20,000 units in over 10,000 patients, and clearly haven't randomized any of those, so we have no clue whether it made any difference whatsoever. So randomized controlled trials are good, as explained in the first preliminary report that's been published by the recovery trial, which talks about dexamethasone in hospitalized patients with COVID. They've also included in that report notes about hydroxychloroquine, which did not have any proven benefit in this study, looking at 2,000 patients randomized to that arm, or Kaletra, lopinavir, ritonavir, that also did not provide any benefit to any patients. So both of those drugs basically should now be parked and shouldn't be given to anyone because of the side effect profiles outweighing risk. Dexamethasone is predominantly useful in the more severely ill patients. And I'll point to D in terms of the Kaplan-Meier curves. So if you came into hospital, you got randomized in the recovery trial to dexamethasone, but you weren't receiving any oxygen. Actually, there's a trend to harm associated with using dexamethasone. However, if you were on oxygen, or you had high flow oxygen, CPAP, or invasive mechanical ventilation, basically you had a significant benefit to having dexamethasone. And the numbers needed to treat are stunning. So essentially, if you look at anyone on oxygen therapy, you can save one person for every 25 that you treat by giving them dexamethasone if they require oxygen. If they end up mechanically ventilated, you save one additional person for every 7 that you treat if you are invasively ventilated. And that is an absolutely stunning result for this drug. And it just shows that the inflammatory effects, once the virus has taken hold, really start to take over and cause people horrendous amounts of damage in their lungs. And dexamethasone clearly has ameliorated some of that. They are continuing on with some other treatments. So this is their current website view, and it shows that they have got a number of drugs that are still under investigation. So low dose dexamethasone, they haven't recruited enough people to know whether or not adults and children are the same, so they're recruiting kids still. Azithromycin is still a potential therapy within the recovery trial. Teclosamab, which is an anti-inflammatory treatment used in rheumatoid arthritis, is under investigation, as is convalescent plasma. Like any big trial, you get lots of emerging evidence coming through, and teclosamab has been studied in the Combacta trial, which is a phase 3 trial, but it's 300 patients. So that essentially means you've got 150 patients being recruited into the active arm of the study, and that hasn't shown any benefit to using teclosamab at this point in time. But as we all know, small phase 3 trials or phase 2 trials don't necessarily tell us the whole story. So recovery is continuing to recruit to the teclosamab arm. And the other reason for putting this particular slide on is that it just shows that social media is increasingly the way that we hear about what's going on. Remdesivir is the other drug that I talked about early on. And again, this is a preliminary report published in the New England Journal of Medicine. And it's important to note that about a third of the patients hadn't reached the endpoint in terms of study follow-up. So it's difficult to know whether or not this is going to hold rigor as the final trial results are published. But it is a drug that has been approved for use with COVID-19. And in this trial, it was a multinational study randomizing patients in a one-to-one fashion against a placebo with a slightly different endpoint to the recovery trial, in that it was the time to recovery, either not hospitalized or waiting for discharge and not requiring ongoing medical care as the positive endpoint. Any other endpoint, so prolonged hospital stay or death, was not in the primary endpoint. And it was pre-planned statistical analysis was stratified according to severity of illness. And the remdesivir trial showed that this shortened length of stay in patients whom were less severely ill. So this is a drug not to be used if you're in intensive care. There was no difference if you were receiving high flow oxygen, non-invasive ventilation, or you were invasively ventilated. The biggest benefit, which is described here, is that you had a significant improvement if you were hospitalized and only requiring supplementary oxygen at the time of study enrollment. And it looks, as secondary analysis is being done, as though remdesivir in this early group probably confers a survival benefit as well. But if you look at D in the Kaplan-Meier curves, you can see that if you're recruited when you're requiring high flow oxygen or non-invasive mechanical ventilation, it does not hold true that this drug helps. So we've got some other platform trials that are going on. So we've got REMAP-CAP, which is another multinational study. It's a randomized, embedded, multifactorial adaptive platform trial. And it's looking at originally community-acquired pneumonia patients, but was targeted rapidly for COVID-19 and has now reverted back to its original all comers for community-acquired pneumonia and investigating benefit for different treatment groups. They've removed dexamethasone from their randomization domains because dexamethasone is now viewed as a standard of care for anyone in intensive care who has COVID-19. But they've kept a number of different arms. So they've got an antiviral arm, and they're still investigating Kaletra. They've got immunomodulatory arms with teclistamab in amongst them. And you can see that there's quite a lot of crossover with the recovery trial, and including that is convalescent plasma. The other interesting domain, and it was flagged in some of the questions, was around anticoagulation. And anticoagulation, there's been anecdotally an increase in terms of the identification of people who have had thromboembolic disease. And we don't know whether that is related to the particularly COVID-19 and how it has its effects in terms of the pulmonary circulation. But we are studying that as part of the REMAP-CAP trial. And that's randomizing people to standard prophylaxis treatment versus therapeutic anticoagulation with either unfractionated or intravenous heparin. Clearly, multinational trials are really important, and who have had the Solidarity trial, and they have reviewed the evidence around hydroxychloroquine and the lopinavir, ritonavir arms, and removed those from their trial on the basis of the recovery trial evidence. But they are still studying remdesivir and lopinavir, ritonavir in combination with interferon. And that's trying to work out whether or not you've got any more robust evidence that is available to tell us that this is a cost-effective treatment. NIH have published all the evidence around the antiviral drugs, and they basically come down with they're recommending remdesivir as the only antiviral drug that is of any use, but they are quite strict in their criteria in terms of who they suggest that should get it. So they clearly state that you shouldn't be giving it to people who are invasively ventilated or on ECMO, because there is no evidence that it will make any difference, and that it should be given to those who are requiring supplemental oxygen, who are hospitalized, because they are the ones that you want to try and prevent getting sicker, and who have clearly got sick enough to need a drug therapy. There are lots of other trials going on. So we're taking part in another trial locally in Stoke, which is one of the national prioritized trials called Stop COVID-19, and is looking at brensocatib, which is a repurposed drug that has an effect on activation of neutrophil elastases in the maturation process within the bone marrow. So that basically stops neutrophils working so effectively to produce elastases and proteases. So when they hit the lungs and get taken into the alveolar space and start driving an ARDS pattern, the thought is that they will not be as potent in terms of driving that inflammatory process, and that may mean that some people who would have gone on to get respiratory failure won't. So this is again starting a drug before you're really sick, when you're hospitalized, and looking at whether or not you can ameliorate the disasters that befall some folk. REMAP-CAP and Stop COVID and a number of the other trials are all working collaboratively with a recovery trial. So all these trials are linking together, and that includes some of the other trials that are non-interventional, like genomic, which Nagesh is the local principal investigator on in Stoke. But there are 26 interventional trials that have been marked as urgent public health studies and prioritised in the UK. Out of that, over 3,000 studies that have been registered in the world. And I've just included a few of those on the screen. Some of these are multinational, like Mermaids, and others are single centre trials. And my final slide just shows you that if you really want to get going with in a pandemic, you have to work across the whole healthcare systems. And the West Midlands has a population that is over 6 million, and they recruited 9,000 people by the 20th of May into COVID trials. So over a matter of about 2 months of active research, 9,000 patients recruited into different trials is a phenomenal result. And we're proud to be one of the hospitals that have helped with that. So on that note, I will finish and let Nagesh take on.
Dr. Chris, I got some questions for you. What do you feel the ideal time to start remdesivir?
So that
ideal
again,
time to, ideal time to start remdesivir in a patient with COVID?
So the local policy is that if you have an oxygen requirement where you're needing oxygen to maintain your SATs more than 92%, then you could be started on remdesivir and dexamethasone. We've got limited access to remdesivir, so the supplies of remdesivir are not great, given that the states bought up most of it. So our limited supplies mean that we are purposing the drug for people who are the sicker end of the spectrum, but not requiring critical care.
Is there a difference between starting in the first week or second week?
Definitely remdesivir is the one to start as early as you can. So if you have someone who comes into hospital that is sick, but not requiring mechanical ventilation or high flow nasal oxygen, then they would be the ones to consider starting.
Is it recommended in pediatric age group, in children?
So remdesivir is adults. There isn't any good evidence in kids. The kids tend to do much better anyway. So it's only really the severely comorbid kids that have been getting admitted to hospitals in the UK. There are very few kids getting transferred to pediatric intensive care units.
Yeah, what about the nebulizer form of remdesivir now is coming in California studies? Nebulizer form of remdesivir. Remdesivir by nebulization.
There's no evidence in terms of that at the present time. In terms of the route that's been published is the intravenous route. That's the protocols available on the that preliminary report. I think I'd steer people away from using any other drugs really, because actually I think there's more harm than good for most of these drugs.
Okay.
You talked about the dexamethasone. Can it be given in diabetics? There's one question in the board where people are asking, can you give dexamethasone in diabetic patients?
Definitely, yes.
Your experience with methylprednisolone and compared to dexamethasone and other steroids?
We didn't use methylprednisolone. If we had someone with wheeze, who was asthmatic, who came in with COVID, then we would happily use prednisolone or hydrocortisone at the same sort of dose that you would give for dexamethasone, but we weren't using high dose methylpred. I think the problem with steroids is that it potentially increases your viral load, which is probably why the signal early on in the recovery data suggests that there might be more harm. So it's the sicker patients that should get the dexamethasone. But clearly, if you've got someone who's got asthma and is coming in wheezy, who's coincidentally infected with COVID-19, then you should treat them as you would do with any asthma attack and give them prednisolone or hydrocortisone.
Is there CRP level is the indicator of this steroid role? If the CRP level is low, can we start steroids or you have to stop?
I think CRP is irrelevant in terms of whether or not you start steroids or not. I think it.
If the CRP level is low, can we start steroids?
Okay, I think Chris's screen is hung up.
Yes.
Yeah.
Sir.
Yeah. Okay. Thank you, Mahesh Babu Garu, for asking all those questions from the audience. And actually, Chris is for some reason disconnected. So, I just want to say thank you. I'll send him the thanks from everyone when we finished.
But essentially, Chris's message to me is very clear. There's only 2 drugs out there that have shown to be of any benefit in COVID so far. One is remdesivir in hospitalized patients on supplemental oxygen, if you can afford it. Second is dexamethasone if you are hospitalized on oxygen therapy in intensive care unit. This is essentially the only good quality evidence with regards to pharmacotherapy agents that is available so far. So I actually wanted to play yes or no game with Chris at the end, because the number of questions that are asked about all kinds of possible pharmacotherapy that is available in the planet is thrown at COVID patients. And I feel really, really sorry for these patients that we are using a mixture of pharmacotherapeutic agents, all that we can do, throwing these at these poor patients without any good quality evidence out there. So as far as I understand, following what Chris has said and following what is available out there and following good quality studies conducted, so far, I'm not saying that these drugs do not work, and Chris has not said it either. But whatever drugs they are, unfortunately, we are all medical practitioners and we are all supposed to practice the evidence that is published. So the questions regarding methylprednisolone, methylene blue, phosphodiesterase inhibitors, therapeutic anticoagulation, convalescent plasma, ivermectin, a combination of antivirals, all of these things are still in the research remit. So we have to wait for a good quality evidence to come through to use them satisfactorily. So far, there are, thanks Chris, welcome back.
Sorry, yeah, computer died. Luckily at the end of the presentation.
Yeah, good. So now I was just summarizing very in a very simplistic message that there are only 2 drugs out there with a good quality evidence. Remdesivir if you are hospitalized on supplemental oxygen, and dexamethasone if you are hospitalized on high flow oxygen therapy or on mechanical ventilation. And everything else remains in the research remit.
Yeah, dexamethasone if you've got any oxygen requirement you should be giving.
Yeah. And there are a number of questions on a variety of pharmaceutical agents like methylene blue, phosphodiesterase inhibitors, ivermectin, a combination of antivirals. Yeah. So I think Chris's line is poor again.
So can you hear me?
Yeah.
I'll go ahead anyway. I think that any other treatment other than methadone and remdesivir, there probably will be some emerging evidence for some of the other treatments over time, but big studies are required to be able to prove or disprove any of the others.
Okay, brilliant. Thank you very much, Chris. I think we will move on. Okay, I think we'll allow one question from Dr. Maharaj.
Sir, normally we are all talking about the starting of the medication. I'm more worried about the stopping of the medication, because I stop all the patients 10th day of 5 days only I give remdesivir, and stopping of steroids of 10th day. We just give only HFNO and Limsi and vitamin, nothing else we give after 10th day. If it requires oxygen also, even hypoxia, they improve much better with high flow nasal oxygen, which I have treated almost a few patients. That's, I just want to ask you, what's your suggestion or opinion and decision?
The question on the duration of therapy, Chris, I think my understanding.
So dexamethasone 10 days, remdesivir, I think it was 14 days. Stopping other drug treatments is really interesting. So the ACE inhibitors are a good example of where there's been a bit of controversy in terms of what to do or what not to do. I think there's a significant amount of emerging evidence that there are cardiovascular events that occur when post-COVID for whatever reason. I think the general consensus would be that if you're on an ACE inhibitor or an ARB, and you're not hemodynamically compromised, that you can probably carry on with those drugs, but they wouldn't be something to start at this point in time either. I think that baseline drug therapy in terms of management for most comorbidities can be often rationalized, but a core management in terms of drug therapy like diabetes management would be key to just keeping someone well. So I think that carrying on with some drugs, there's clearly a rationale for.
Thank you.
Okay.
Nageshwar, one question from my side, only one question.
Yes, please.
Sir, most of the patients, COVID patients, after discharge, they come again after 1 or 2 weeks with the many complications. One of the most common I have seen is pulmonary fibrosis, and another thing is CVA. So is there any comparative study between the early weaning of the steroid and the late weaning of steroid to reduce the complications?
No, I mean, the recovery trial was 10 days of dexamethasone. They've not looked at comparative length of study, length of drug. I think that clearly it is interesting to see that people are getting more problems in terms of stroke. I think that when you look at people who have got significant cardiovascular risk, making sure that they're discharged on an aspirin if they came in on an aspirin, I think would be really important. And if they've got during their whether or not be calculated, and if you have paroxysmal AF, that will confer some risk for you. I don't think we've got any good evidence in terms of knowing what to do with paroxysmal AF in critical illness. But if you've got a history of paroxysmal AF pre-critical illness, then they should probably be anticoagulated to try and reduce the risk. I think that's probably as far as I can go with that question.
Thank you.
Right. Okay. I think we are slightly behind the schedule. Thank you very much, Chris. And we will move on to Nehal Patel, who is a consultant colleague of mine in intensive care at Royal Stoke University Hospital. He is also from an anesthetic background, and he does his anesthetics in high-risk upper GI surgery. He plays a lot of significant role in education. Nehal is our faculty tutor for Royal College of Anaesthetists, and he's supported a lot of trainees over the course of last 5 years and made them into successful consultants in intensive care. He runs a lot of courses nationally. He runs the fellowship in intensive care medicine FICM course twice a year, which put Stoke in a lot of limelight. He's also an EDIC examiner, so he has got a significant role in education in intensive care sector in the intensive care community. As we were approaching the COVID crisis, Nehal played a significant part in educating the non-anesthetic medical professionals in getting ready for combating the crisis. And he, with the help of a few other anesthetic and intensive care registrars, he conducted quite a few teaching sessions, preparing non-medical professional, non-anesthetic, non-ICU background specialties, gearing up in treating the COVID crisis. So I wanted Nehal to share his experiences in using up whatever resources you have, because this is not the time to cope with one resource. This is the time to bring everything together and fight the crisis. So thank you, Nehal, for your talk. Over to you.
Nageshwar, thank you very much for that very kind introduction. I'll just start sharing my screen. All right, hopefully you can see my screen now. Yeah, Nageshwar?
Yes, we can.
Okay, great. So thank you again, and thank you for the Indian Society of Anesthesiologists AP division, the chairpersons, presidents, and all the friends and colleagues who have given up their time to watch this webinar. Just okay, so going to the resource management. I mean, broadly speaking, the resource management in terms of managing the COVID crisis involves these four things. It's obviously not evidence-based, or people haven't experienced this kind of thing before. So it's just about knowing what you have, and then knowing what you need extra, and then mobilizing your resources as you can. So what is your setup of the hospital basically? Where do you work? Is it a private sector? You're in a government sector? Is it a corporate hospital? What is your infrastructure? And I've heard quite a lot about specialist COVID hospitals coming up, but there may still be areas in the hospital where there may be a mixture of COVID and non-COVID patients. So what's your setup like that? Have you got specific green wards for non-COVID patients, red wards for COVID patients, etc.? Who is actually going to give the treatment to these patients? Have you got enough anesthetists, intensivists? Have you got enough resident staff? Have you got enough nurses? Where are all these resources coming from? How do you actually give the care? What do you do on a daily basis? Do you work in a shift pattern? Have you got localized protocols or guidelines that you have devised depending upon your own needs? And what additional things you need? So basically it comes down to, have you got enough space to look after all these people? Have you got enough equipment, and have you got right kind of people to be able to deliver the treatment in pandemic? So I'll just give you a little bit of an example of my own hospital. So in the middle is my typical ICU bed. And we got about 36 beds in a sort of in a normal day-to-day situation before the COVID crisis. And that includes a mixture of general medical, surgical, and trauma beds. But clearly 36 beds weren't going to be enough. And we were asked to increase our capacity to up to 160 beds, which is clearly very, very ambitious. So what did we do? We went with our help of pediatric intensivists. We went into pediatric intensive care, and they were really, really good. They transferred all their sick kids out to sort of regional big hospitals. So the pediatric ventilators and their beds were available for us to use. So that got us about 8 beds or so. Then we went into theater recovery area, the post-anesthesia care units, which gave us additional 12 beds. We also went into cardiac critical care because all the routine cardiac surgery was cancelled. In fact, all the routine surgery, orthopedic, everything was cancelled, so that we could utilize all the theater staff and other people in a more efficient way. But we shouldn't forget the role of the normal wards. So on the bottom right corner, we've got some normal wards. And these wards were also converted into either COVID or non-COVID wards. And in fact, the COVID wards could look after a lot of hypoxic patients needing up to 8 liters of oxygen. So they took a lot of pressure off, and they could also be used as step-down wards when people were getting better in our ICU. What else happened in the region? So obviously in a big state like Andhra Pradesh, your colleagues, your friends in other places could help out if there is a lot of pressure in your hospital. In the West Midlands, which is our region, there was a dedicated transfer service. So if a particular hospital got overwhelmed with COVID patients, few ventilated patients could be moved out, and there was a dedicated transfer service set up for that, so that you couldn't be taken away from your normal day-to-day job. Like I said already, the kids' ICUs were all centralized, so we could use the local beds, routine heart surgery, orthopedic surgery, and these sort of operations were cancelled. In fact, our hospital has 33 operating theaters, and only 4 were allowed to continue to operate to look after the emergency patients only. So that released a lot of anesthesia staff, theater staff to be able to help us with the crisis. Obviously, expansion of the ICU capacity doesn't mean that if we put up some extra beds and put up some ventilators. It requires much more than that. So we need trained ICU nurses or skilled ICU nurses. Obviously, they are in short supply. Also, we have to account for the sickness. Some people go off sick. They are isolating themselves. They've got COVID themselves. So we need trained people to look after critically ill people. We also need junior resident staff. They are very critical, and there is no way we can just run the shop with a few residents. I was just talking to my friend in Gujarat who runs an ICU, and I was just so sad to hear that he's got about 40 patients in his ICU, which are all COVID. 50% of them are ventilated, and he runs the shift with 1 or 2 residents. Clearly, that's a real challenge, a lot of burden, and can affect your well-being. We obviously need equipment, monitors, syringe drivers, drugs, infusions, etc. So how did we go about the business in our hospital? So basically, ICU and anesthesia became one. We became one entity. And we started working in shifts. So all throughout 24/7, around the clock, there was a senior consultant presence on the floor. That helps sort of streamline decision-making. There is leadership, patient flow is better, and there is always a nominated ICU gatekeeper who's an ICU consultant who will make decisions about which patient to come into ICU, which patients are suitable, who needs escalation, etc. Anesthesia consultants were a huge help. They formed part of the intubation teams. So they were on the intubation teams with anesthesia residents. And if anybody needed rescuing on the wards in A&E, they would go and help us out. Any outlier areas, non-standard ICU areas, for example, theater recovery, they would look after the patients. So ICU clearly provided an oversight, but we needed the manpower and the skills that only anesthesia could offer at that time. In order to reduce the burden, we made sure, or we tried as much as possible to limit the consultant-patient ratio. So hopefully no more than 15 to 20 patients for a consultant. Junior staffing, we ensured that there was 1 junior looking after 8 patients, or at least 1 junior for 8 patients. So that allows kind of breaks. Working in PPE for long hours, specifically in India with the hot conditions, can be even more challenging. And there were residents from anesthesia, ICU, emergency department, general medicine, surgery. We utilize all of these people. Some of them were already doing their modules and blocks in ICU, but few others were inducted very, very rapidly. There were nurses deployed from other areas, including research nurses, organ donation specialist nurses, OPD staff. And even if they don't have specific ICU related skills, they can still help with simple tasks, taking patients' observation, giving them simple hydration, talking to their families, stocking and making sure that enough PPE was available, supporting other staff. So everybody has a role to play in this situation. And we just need to have a way and a method of using all available resources. This is just an example of how our teams work. So we prepared 6 teams, and in each team there were a lot of anesthesiologists and intensivists, including juniors, and we worked through the shift pattern. So that's just one example of how we can manage the situation together. Now, obviously, if we are going to take people from outside ICU and anesthesia, they need some quick training. They need some quick skilling. And it's not that bad. Not everybody needs to be able to intubate. And not everybody needs detailed knowledge in mechanical ventilation. But there are a few other things that they can do. And there are some really outstanding resources available out there. For example, this one prepared by Intensive Care Society and the Royal College of Anaesthetists. And it gives detailed guidance about what you can teach these trainees in a short period of time. So essentially, you just need some basic clinical skills of assessing patients and kind of prescribing things. They need some basic skills in resuscitation. Doesn't need to have advanced skills. and some areas of non-clinical skills, how to work in big teams, how do you use the PPE, that sort of thing. And how can we put this thing in action? This is something called Better Together in Action. And you probably wouldn't believe, but we used the surgeons, surgical residents who came, because all the elective surgery was canceled. They could be deployed to ICU, and they would come and help us with proning. They would come and help us with reviews. And I'm sure Nageshwar has used surgeons to put things like chest drains and things. There is always a skill that they possess that we can utilize to our advantage. We had dedicated input from the cardiologists and the cardiac sonographers to help us with routine echocardiography. So that takes away pressure from you. So basically, you need to think about what you have available in your institution or around, and how they can be useful in terms of integration in your teams. Obviously, if we are going to take people from outside ICU, they need some sort of guidance. And hopefully your hospitals have some sort of daily review checklist. So that gives a standardized plan for the assessment and management of patients. And if everything's just standardized and kept simple, and everybody can follow that plan, it reduces variation and increases the safety. So you can prepare something like this in terms of daily assessment of airway, breathing, circulation, disability, and make them aware of what is required of them. It is achievable to an extent. And there are some excellent resources out there. If you wanted to look at these things in terms of how you can train up juniors, it's all out there. If you are looking to, so that's about people and about human resources. In terms of equipment and the devices and things that we need, WHO has published a nice list of essential medical devices that one needs in terms of managing the COVID-19 patients. And it's downloadable, and you can have a look. It basically just talks about important things that are required to manage these patients. Equipment, when it comes to that, there is obviously a few essential things that we need. Obviously, we need some oxygen delivery systems. We need the actual oxygen. And Nick Coleman has gone on and talked quite a lot about issues with oxygen supply. So I won't dwell too much deep into that. Obviously, need some monitoring equipment. We need ventilators, and you can resource ventilators from all possible sources. You can use transport ventilators, use the older machines, or kind of cross-use machines across the hospitals. Obviously need sedation and other infusion medications. Throughout the UK, at different points, there was severe shortage of some of these medications. The most prominent being cisatracurium, a neuromuscular blocking agent, which was commonly used for all intubated and ventilated patients. We need critical care ultrasound. Obviously, we all know the role of critical care lung ultrasound and echocardiography being really, really useful during this crisis as a means of bedside assessment of the patients. So these are the some of the essential things required for management of a critically ill patient. Nick has obviously again spoken about the appropriate use of oxygen. We devised, this is the guidance from NHS England, just to make sure that we use the oxygen appropriately and efficiently and avoid any kind of wastage, because obviously it's a precious commodity. And it gives some stepwise escalation plan in terms of how to increase oxygen delivery. And again, this is kind of borne out by the British Thoracic Society guidance. And the point that I want to make out here is that not everybody who's on oxygen needs to come to ICU. And I'm pretty sure these principles are being observed and practiced in India as well. But they would look after here on the wards. Anybody needing up to 40% oxygen can be looked after on a respiratory or an infectious disease COVID ward. And accepting lower oxygen saturations where possible. So going down to as low as 90%, specifically if they are suffering from COPD, etc. Again, I just wanted to highlight this oxygen incident. If you are running obviously a hospital or a facility, whether it's in a dedicated ICU facility or outside the ICU or a non-conventional area, temporarily converted into ICU, we need to know how many patients you can look after who needs high flow oxygen. You need to know how much oxygen supply you've got. Obviously, some hospitals will have the big tank, some hospitals will have cylinder manifold, and some will have just standalone cylinders. The problem with the standalone cylinders is that obviously there is a hazard of trip and damage, but also there is no warning when the oxygen runs out. There is no alarm or siren or anything like that. And there was a real issue in the UK itself at the height of the pandemic, which was in the second week of April, when one particular hospital north of London ran out of oxygen basically. And there was a major emergency there. So it is a real life problem. Clearly, we talked about ventilators, the oxygen delivery devices, the human resources, and some people who need a renal replacement therapy. I mean, I'm not sure how the situation will be dealt with in different situations in Andhra Pradesh or in India, but need to have some contingency plan for how a renal replacement therapy or dialysis can be provided, because some proportion, not insignificant proportion of patients do develop acute kidney injury requiring renal replacement therapy. How are you going to use the machine? Do you have enough staff who can use the machines? Do you have enough sets, etc.? So we had to make some plans regarding that. And fortunately, we have Chris Thompson, who's you just heard from as a renal physician, very helpful in terms of making such plans. Royal College of Anesthesia issued guidance if you run out of certain medications, neuromuscular blockade drugs, intravenous infusions, sedatives, what alternatives can be used. Again, this was really useful, and we had made our own little checklist in terms of what we would use if things were not available. And at the present moment, we are still short of cisatracurium, so we are using rocuronium. So these are some real challenges. Obviously, the infusion pumps can be in short supply, so you may have to mix things, use things as an intermittent bolus. So you just have to think about innovative ways of using your resources. There is again some useful guidance available. There are a lot of publications. If the resources are limited, you could look at, there is some guidance published in Critical Care. All these things are open access. But basically, if you look at this, the main point, the take-home message from this publication is that you look at your infrastructure, look at your monitoring, but the main emphasis is that avoid overuse of non-evidence-based methods. And I think that's been already discussed, and Nagesh has mentioned that previously. With simple and basic and standard treatment for our patients, even if they are critically ill, requiring high amount of oxygen, they can still be looked after if our basic systems are in place. They don't necessarily all have to have sort of hi-fi treatment, but in order to provide those standard treatment with oxygen and supportive care, we need some resources in place. The World Federation Society of Anesthesiologists has got, again, lots of interesting resources on their website. If you're planning on providing this kind of service in your area, it talks about various ventilatory strategies, intubation pathways, etc. So again, something that may be of use or interest to you. And I think I've just given you like a little flavor of where to find things and what you may need to think about when you are providing these challenging services. But above all, I think staff well-being and morale is really, really crucial. We were in a position to maintain this even at the height of the pandemic because we were well supportive of each other. Our teams were not short-staffed. At least I don't think they were short-staffed. And there was mutual respect and compliment for each other, and we supported each other. And that's how we partially got through the height of the crisis as well. Ultimately, people need breaks, they need rest, hydration, and if there is only 2 people managing the whole show, that's not good for anybody. You need people who can show leadership, who are flexible, who are kind of knowledgeable of people's needs, and that really helps. And people just need to be able to work below their experience because this is we are all in this together. So we just need to be able to punch our weight in. And lastly, I just wanted to share a really inspiring experience. So on the picture here, obviously, you know, Nagesh is on the left in the picture here. But we have Murli Vallabhaneni, one of our consultant anesthetic colleague, and he has given me his permission to share his picture here. He survived mechanical ventilation from COVID. He was with us. We were very worried about him. Interestingly, he's also from AP, Andhra Pradesh, I think. He was very poorly. He was mechanically ventilated, invasively ventilated. We just gave him standard treatment with dexamethasone and just good medical and intensive care for him. He made a full recovery. And actually, I'm so proud to say that recently, only yesterday, him and Nagesh with few others climbed a mountain, the highest mountain in Wales, 3 months after being taken off the ventilator. So I think that just goes to show that just with good teams management and management of basic resources, we can achieve a better outcome. And I'll stop there. Thank you. I'll take any questions if you have.
Has any of the chairpersons got any questions for Nehal? Thank you, Nehal.
Thank you.
It's done very well and very well explained how to organize the thing. And I would like to share this one. Vallabhaneni Murali is my junior and he was my student as well when he was doing a residence in anesthesia in Manipal. Convey my regards to him, please.
Sure, well done.
Thank you.
So, Nehal, I just want to ask one question.
Yeah.
See, India, as we both know, is a land of independent practitioners.
Mm-hmm.
It is not a public health service entirely like NHS. And you know, if you go to large parts of India, then what you see predominantly is an orthopedic surgeon doing his own thing, a general surgeon doing his own thing, and anesthetist and intensive care predominantly hospital based. So in a hospital like ourselves, a university hospital, it is very easy for a vascular surgical registrar to come and prone the patients for us because he is currently employed by us. He is getting his money paid by us, and he has to make justice for the money that is paid. Whereas in a land of independent practitioners, predominantly freelancers like in India, it is a little difficult because on one hand, people are very, very worried about the COVID status and would like to avoid it as much as possible, and would not be in any position to go above and beyond their normal level of expertise. So I'm just saying, I mean, I just wanted to hear what your comments are going to be, because I think it is an extremely difficult situation what our Indian colleagues are facing with the limited supply of the skill.
I think that's a very valid point, Nagesh, and it's just the heterogeneity of the health service that makes it much more difficult. No easy answer for that. An orthopedic surgeon who's done a single-handed practice for 20 years in his own hospital, to attach him to a COVID ward is going to be very, very tricky. But if you're in a government hospital, at least, even if you don't expect any help from a senior orthopedic surgeon, at least his or her resident should be able to help. And there are so many other junior doctors in other different specialties. When we ran the training session, the teaching session, which we delivered in just over 3 hours in our hospital, there were trainees from dermatology, there were trainees from ophthalmology, there were ENT residents, and there was about 40 of them, all willing to help. Obviously, the junior they are, the much more enthusiastic they are. You need to capitalize on their enthusiasm. Hopefully, not with many comorbidities, these people. So hopefully, less likely to get exposed and things. So yeah, I think that's the only way you can. I don't know whether the government or at the administrative level, at the district level, people with power, people with authority can enforce these things. I don't know.
Now the health authorities, even the state and the center, is enforcing all the department. Whoever has a basic qualification of MBBS should come and work with the COVID teams.
That's
So
fantastic. Yeah.
now without their support, even India and Andhra Pradesh, is difficult to run the COVID centers, dedicated COVID health centers.
Yes, excellent. Thank you. Thank you, Nehal. Has anybody else got any questions for Nehal regarding resource management? Clearly, this is not as favorite as the pharmaceuticals.
That's okay.
But it is important. But it's definitely important.
But it's very important, sir.
Of course,
Because if all the results are there, then only we will work now.
Yeah, practically not possible for us also.
Yes, sir.
This is the most important aspect of our care.
Yes, sir. Here also in our medical college, we have to train all the preclinical anatomy, physiology, biochemistry, pathology, all the people. We give how to wear the PPE from starting, how to wear the PPE to how to manage the patient, basic management. A lot of training is needed for house surgeons and postgraduates. It's very tough job, sir. Tougher than managing a patient.
Yeah, totally agree.
So I think that somebody talking in the background, can their phones, can their screens be muted, please? So like I gave a little summary for Chris, I think essentially, in my perspective, the most important aspect of our care is the resource management. It is not the mechanical ventilation that is going to save a large number of our patients, nor is the pharmaceutical management. It is only going to be using our resources properly and simple housekeeping in our intensive care that is going to save a large number of our patients. It is not going to be the drugs. It is not going to be the ventilator. The whole credit should belong to us. The simple housekeeping in intensive care is going to save a large number of our patients. And that is, I think, the main message from Nehal.
I think it's evident in our numbers as well, isn't it, Nagesh?
Yes.
Even those people who are invasively mechanically ventilated in our unit, nearly 65% have survived. So the mortality rate is only 35%, even for invasive mechanical ventilation. And people have improved after 10 days, 12 days of invasive mechanical ventilation. And we haven't used any plasma therapy or tocilizumab or remdesivir or anything.
We have not used a remdesivir on a single patient on our intensive care unit. All we have used dexamethasone also predominantly during most of our COVID period was for research purposes. And once it is established in research, it became the standard of care. But as Nehal said,
following day.
Yeah, the following day, yeah. So it is not the drugs, it is not the ventilator, it is us, and is us managing whatever the resources that are available, and the simple day-to-day ICU management in an organized, tidy fashion, I think is the biggest difference in saving as many patients as we can.
First principle is always do no harm. So that means trying to do the basics really, really, really well.
Yeah. Okay, thank you very much, everyone. Venugopal sir.
I think Venugopal sir, he left. He had some emergency work.
Sure.
And on behalf of our president, I thank to all, including Nagesh sir and Nehal sir and Chris sir and Nick sir and all the participants and all the ISAAP national leaders, Dr. Kameswara Garu, Dr. Chakarao Garu, Dr. Mahesh Babu sir, and Dr. Mohan Maharaj sir. Thank you all for participating. It's a good academic feast, sir, actually, because day to day, nobody knows what is the treatment of the patient. So finally, the conclusion is remdesivir and dexamethasone. They are two are the evidence-based drugs what we have to use. So thank you all. Thank you, sir. Thank you, Nageshwar sir, and thank you, Nehal sir, once again. Thank you, Chris sir and Nick sir. I think thank you all, sir. We shall close the meeting. Thank you, sir. Thank you.
Thank you, everybody. Thank you very much.
Thank you. You are all doing a very good job. Thank you.
Thank you.
Thank you very much, sir. Thank you, sir. Thank you.
Thank you, Dr. Nick.
Again, we will meet, sir, soon.
Sure.
It's evidence-based.
This is an opportunity to establish.
Dr. Nagesh sir, where are you from in Andhra Pradesh?
I'm actually from Miryalgoda.
Okay, you had your education in Guntur.
No, well, I did, yeah, actually, Guntur for my intermediate in Vikas, but then I studied in Warangal.
Okay, you were UG in Warangal.
And my medicine is in Warangal, yes.
Okay, sir. Okay. Well, nice to see you, sir. Thank you very much for hosting a very wonderful thing.
Thank you.
Thank you.
So
Thank you for your time.
Thank you
for your time.
Thank you very much. Thank you, Dr. Christopher, Dr. Nick. Thank you very much.
Thank you. Bye.
Thank you, sir.
Bye bye. Bye now.
Bye bye.